I guess if you think of where we were when we planned the original RSU, these units which provide sort of intermediate respiratory support to the sickest patients with respiratory conditions were very common in Italy, where they were called respiratory high dependency units. There were probably about 80 units across Italy when we were planning our own unit, and we were probably in single figures in the UK. But essentially, it gives you the ability to give non-invasive ventilation. So that's breathing support, a machine that enhances someone's breathing efforts and supports their breathing when they're very unwell outside of critical care. There is sometimes the impression that non-invasive ventilation is a cheap alternative, but actually in many conditions, it's much better. So you don't sedate and paralyze the patient, they're awake. You don't breach their airway defenses by putting a bit of white plastic, an ET tube, where God didn't intend one to be. And therefore, because the patient's more active, they clear their lungs more normally, actually outcomes can be better, particularly in COPD, but in many other conditions. It's a relatively new thing, I would say. There were a handful of units around the country that in existence already. I wrote the first business plan for an RSU in 2007. So the concept itself is actually not that novel per se, but many trusts had not invested the money and resources required to establish a fully fledged unit. And in many hospitals around the UK, these patients were being treated in open respiratory wards, which obviously is not what you'd want during a pandemic. We were fortunate in that we were ahead of the game. Well, so my background is non-invasive ventilation. So I did my PhD in home ventilation and motor neuron disease, and that trial changed worldwide practice. There's a threefold increase, even in Paris, for instance, either side of publishing RCT in the proportion of people with motor neuron disease who were getting a ventilator at home. When it came to the trust, there's already very good data from Mark Elliott in Leeds and his team that acute NIV improves survival in the most severe COPD exacerbations. But in Northumbria Healthcare at that time, there were only 3 ventilators that were specific non-invasive ventilators across the trust, and we were offering support in open respiratory wards. The settings were probably not optimal. So within a year, starting in 2003, we had a robust guideline. We tripled the number of ventilators. Physios could only be on call once they completed the training, and we only used the specialist physios to initiate treatment, whereas other places, they let doctors have a go. And I think, particularly with the very conscious patients, very important that introduction to treatment is very carefully provided in a reassuring manner. And I would say in that respect, the physios are the beating heart of the service. And I think that's key to our outcomes. So when a patient was deteriorating, the physio would move with the ventilator to where the patient was. We use condition-based settings, so we optimize the treatment for individual patients and then rescue them to the respiratory ward. So even before we opened the RSU, our inpatient mortality was about 13% compared to 25% in COPD exacerbations in the NC-POD national audit. And we saw similar things at BTS audits as well. But by opening the RSU, it concentrated all the patients in one area. It enhanced the staffing levels. It allowed the nurses who are looking after the patients to gain more specialist experience alongside the NIV physios. And we had respiratory consultant physicians on call 24/7 with a daily presence, which simply wasn't happening before. And mortality in COPD dropped from 13 to 9%, but there's an even greater fall if we look over inpatient plus 30 days from 18 to 10%. And in that respect, it's clearly the right thing to do. The advantage we had when the pandemic struck was we changed very, very quickly, adapted what we did. So instead of bringing the ventilator to the patient, we rescued the patient up to the RSU, but we constantly kept the bed free. We protected those beds, and the trusts were very supportive in that initiative and made sure that the flow could happen in a swift way and a safe way for patients. And obviously PPE was very new. So I was on one of the very early weekends before we had proper cooling on the unit, and in a waterproof gown and the full PPE mask and everything else. I can tell you it was very unpleasant, but very rapidly with proper industrial cooling units, which made it a much better environment both for patients and staff working there. And it's not just the non-invasive ventilation. I mentioned we have conservative oxygen target saturations. There's an ingrained belief that more oxygen is good, and when you're sick, you should turn the knob as far as you can round. But actually, in many conditions, that increases the risk of death. And in a way, the national guidelines have not yet been revised to reflect that evidence. But it's often said that the UK is a speedboat compared to the ship of the EU in delivering vaccines. Well, in adapting our practice, we were very much a speedboat within the UK, and we'd already set very conservative oxygen target saturations across a range of conditions, which is exactly what you need in this period of time. And it meant we never even came close to exhausting our capabilities to provide oxygen. But we introduced things like awake proning as well, which is where you turn the patient upside down. So in COVID, the lungs are leaky and the fluid will go to the lowest part. By turning the patient over, it allows parts of the lungs to recruit, to perform better. And we actually do that in advance of giving them acute CPAP therapy. But we also saw lots of blood clots, so we very quickly introduced enhanced thromboprophylaxis, that's additional medication interventions to reduce the risk of blood clots, and again improve outcome in that regard. I think the thing that struck me is everyone working together, and you need all elements. You need the managers to support protecting the beds. You need ED to work in a very fluid way with the respiratory support unit and the rest of the services. I've been very struck by, just the extent to which the nurses and physios on the respiratory support unit, the dedication to the patients. And they were experiencing something very frightening, very new. There was a threat to themselves. There was a much higher mortality than we're used to. I've mentioned our mortality in COPD and other conditions, literally was around 10% when you were seeing mortality of 25% elsewhere. Our death and mortality in COVID is much higher than that just because it's a much more serious condition, but compares very favorably if you look around the rest of the country. But nevertheless, that's, we didn't know that at the time, and we were dealing with it and dealing with the deaths. Relatives couldn't visit. It was staying in touch with them and that communication and making sure that happened. And then the junior doctors working alongside as well. So I think the fact that everyone was in it together, and there was a very strong spirit that we're going to get through it together, has helped us greatly. So it's not the guideline, it's the people who implement it that make the difference.